Hello, thanks for your interest in our research. My name is Ningning Cheng, a Year 3 PhD candidate from the Chinese University of Hong Kong. This is a joint work with Professor Li and Professor Ben. Health information technology has tremendous potential to make healthcare provision safer and more affordable. Governments around the world have been trying to promote HIT adoption in hospitals. At the same time, health policymakers gradually turn to pay for performance schemes to achieve the same goal by financially incentivizing hospitals. What could be potential impact that P4P programs have on hospital HIT adoption? They could serve as a double-edged sword since they motivate participating hospitals to expand IT capability as a means of quality improvement while taking away resources originally allocated for HIT. To the best of our knowledge, this study is the first to investigate whether and how the introduction of P4P programs influences the overall HIT adoption levels in hospitals. I'll start from our research questions, and then I'll walk you through empirical models and results. We leverage a natural experiment in the US healthcare system, where a pair of complementary P4P programs were introduced in the fiscal year 2013 to a subset of hospitals. The pair of complementary P4P programs are the Hospital Value-Based Purchasing Program, HVBP, and the Hospital Readmission Reduction Program, HRRP. Note that both programs were launched in the fiscal year 2013 and mandate the same group of hospitals to participate in, meaning that hospitals either participate in both programs or none of them. It's therefore impossible to tease out the standalone effect of one program on HIT adoption, as they are complementary P4P programs sharing the same design, and our primary goal is to investigate P4P programs' impact. It's reasonable to consider them as one single treatment in this empirical design. In the next few slides, I'll introduce research questions and discuss mechanisms through which the introduction of P4P programs might affect hospital HIT investment. On the one hand, past research has well established the positive correlation between hospitals' IT use and many dimensions of hospital operation, such as service productivity, patient safety, and patient communication. These positive impacts of HIT are closely connected to the target metrics of many P4P programs. On the other hand, hospitals' responsive efforts to P4P programs may involve substantial financial resource investments. Concerning a tightened budget, hospitals might not prioritize HIT investments under P4P programs. It's not clear from literature whether P4P programs lead to a higher or lower overall HIT adoption in hospitals. This motivates our first empirical question. For our second empirical question, hospitals are subject to social influence from peer hospitals through information transmission and network externalities. Social influence is enhanced when two hospitals are affiliated with the same MHS, which gives rise to the spillover effect. Our second research question thus examines whether P4P programs have any spillover effect. Past research has also found that health technology adoption is affected by the competitive structure. In general, new treatment technologies diffuse faster to competitive healthcare markets, since returns from the new technology are greater there. In face of P4P programs, the benefits of increasing HIT capability are more likely to outweigh the financial cost for these hospitals in competitive markets. Smaller hospitals are less likely to obtain tacit knowledge on HIT implementation from outside the system. Also, it's harder for them to achieve economies of scale all by themselves. Therefore, they might rely more on support from system headquarters or other member hospitals for information or positive network externalities. Following the above arguments, we ask our third research question that how the spillover and treatment effects of P4P programs differ across hospitals with different sizes and market structures, respectively. To address the three research questions, we collect data from three different sources, namely the AHAN user database, the HIMSS analytics database, and official website of CMS. We match hospital information in different sources using Medicare ID numbers. Our observation window spans from 2009 to 2016. The resulting panel data is unbalanced, with 31K observations and 4K hospitals. We use the number of operating HIT applications to measure the overall level of HIT adoption for each hospital. We divide hospitals into three groups based on their eligibility for the two P4P programs and system affiliation. We measure the level of market competition in the hospital referral region using the widely adopted Herfindahl-Hirschman index. The index ranges from 3 to 1, with a high number indicating a more concentrated market. Hospital size is operationalized as the total facility expenses in the hospital. We employ a difference in differences model with two-way fixed effects on hospitals and years. To answer our first two research questions, we estimate equation 1. XIT represents a vector of all the time-varying control variables. Alpha 1 and alpha 2 can be interpreted as the treatment and spillover effects respectively. To address our third research question on the moderation effects, we estimate equations 3 and 2. Here, HHI is a time-invariant variable generated by taking the average of the time-varying one. Since we demean it before estimating the model, beta 1 captures the treatment effect on hospitals in an averagely competitive market. Beta 2 captures the additional treatment effect on hospitals with 1 unit increase in HHI. Similar to HHI, we transform the time-variant log expenses into a time-invariant moderating variable. Beta 3 captures the spillover effect on a non-participating hospital with average operating expenses. Beta 4 captures the additional spillover effect on hospitals with 1 unit increase in log expenses. Before estimating our DID model, we apply the Kosinec-Zatmachin method to balance treatment and control groups, and then conduct an assumption check for parallel trend. CEM matches treatment and control hospitals based on pre-treatment covariates. We manually cosine continuous variables based on the features of the data. The L1 statistic reduces from 0.761 to 0, meaning that the matching is perfect on the manually cosine levels. Following the convention, we use the interactions of treatment dummy with the year dummies to test the parallel trend assumption between treatment and control groups, similar for the spillover group. The figure displays the coefficients of the interaction terms over time. All of them are not significant before the program implementation. We then estimate the three equations with matched data. The coefficient of the interaction term treatment multiplied by after is significantly negative, indicating that the implementation of P4P programs has a negative overall impact on the HIT adoption in participating hospitals. Looking at column 2, we can see that this negative treatment effect is more pronounced for hospitals in the less competitive market. This result implies that hospitals in less competitive markets are much more vulnerable to the negative impact. The coefficient of the interaction term spillover multiplied by after is significantly negative. It suggests that even though some hospitals are not participating in HVBP or HRP themselves, their HIT capability is negatively affected to a similar extent to participating peers. Looking at column 3, we can see that when the hospital size is above average, the negative spillover effect is smaller in magnitude or even non-existent. To wrap up, in this study, leveraging a natural experiment in the US healthcare system, we are able to causally infer whether and how the implementation of two P4P programs, HVBP and HRP, influences HIT capability in both participating and non-participating hospitals. For healthcare policy design, this study is the first to investigate the potential impact of P4P programs on hospital HIT adoption, identifying an undocumented side effect of P4P programs that might impede long-term quality improvement for hospitals. This study also has implications for multi-hospital system management. Attention should be paid to the spillover effect policies like P4P programs, as they might not only impact participating hospitals but also non-participating members, especially small hospitals that possess fewer select resources and are more reliant on peers. Thanks for watching. Please leave your comments below. Thanks for your time and your comment in advance.